So once again, thank you for the invitation. It's a big privilege to be here, and thank you, Mr. Chairman, for introduction. Actually, I would like to congratulate you that you are still here, still alive. It was a long day, and I have only 6 minutes to speak about the AC joint, I see. But it's a little bit more complicated when we obviously think about where the problems come. So what do we have as a base of this problem? I think the pain is the most common source that the patients are coming, visiting us and saying, sorry, something is working wrong. I feel the pain after the game, during the game, I cannot attack, especially the overhead athletes like volleyball players, baseball pitchers. Then we have instability in a different appearance of the instability, not only this typical traumatic instability, which we know from the Rockwood classification, but also minor instability. It's so-called the hidden instability, especially posterior hidden instability, and instability and the pain. What is the source of the pain? Of course, during the examination of the patients, we can easily palpate this joint, and we can feel the tenderness in there. The majority of the patients has this symptom, but sometimes the pain goes directly to the neck, and sometimes goes to the scapula, and very often it goes along the clavicle to the sternoclavicular joint. This is something what we can mismatch. There are several causes to this pain. As a post-traumatic arthritis, we know that it's one of the first joint which goes into the arthritis after the neck, the second one. Obviously, in between the 20, we do not have preserved any intraarticular disc anymore. But also there are other rare, more or less rare diseases behind. In epidemiology, we have to search for different activities, of course, but you can see that in a very sensitive 3 Tesla MRI, the findings show that there is about the 20% of minor or mild osteoarthritis in AC joint in this group. Also in lacrosse, very specific sports, the people complain of the AC joint sprain, and it's obviously half of the population of this sportsmen. So these athletes really deserve our care. And in swimmers, about the 10% of the professional swimmers complain of the AC joint tenderness. In epidemiology, in the general population, there is almost 10% per 1,000 per year. So it creates really relatively long term of the absence of the sport activity. And if there is really the major injury, they can last even 70 days in average during the season. In the evaluation, we have to focus on the patient history, of course, all previous injuries. We have to examine the patients. Then we have to make all the radiology, the plain radiology, Sanka view, or ultrasonography, MRI, CT, whatever we want. But also we have to remember that there is a very intelligent tool in our hands, which is a direct selective injection. This is a very sensitive tool. According to the AC joint problem. Why? I will go back immediately to this topic. In evaluation, during the examination of the patients, we have to try to find the tenderness under the palpation. If you palpate the AC joint only from the top, sometimes it's not significant. Try to palpate all over the joint, especially in posterior aspect of the joint, because the sprain of the posterior ligament could create the pain and could create an inflammatory reaction in this environment. In a Sanka view, it's a very typical view for the AC joint, AP view for the AC joint. We can see all arthritic changes, and also we can see some forgotten forgotten disease, which is distal clavicular osteolysis. It could be due to the previous trauma, but also there are some synovial changes which could create this reaction, and sometimes we don't know if it's DCO or it's just inflammatory reaction on the edge of the clavicle, but it can happen, and we have to focus that. It's very easy to recognize in a normal obvious X-ray, as well as osteoarthritis. It's also the most common pain, and mostly in elderly patients. But in a group of overhead athletes, unfortunately, it could be also quite common. So focus on that, watch the X-rays precisely. If there is a narrowing of the joint space, just verify contralateral side. If there is a closure, then think about the arthritis, think about the intraarticular disc which is involved in the problem. And also, I don't know if you find this, I have no personal images of that, but I had one patient, one volleyball player. I was pretty sure that it's AC joint problem. It was treated conservatively for 3 months, without any response. And then I inject the AC joint, and I said, no, you're kidding me. It could not be painful. I just pressed there at least 4 centimeters of lidocaine. You cannot feel the pain. I feel the pain. This is this pain. And it was the cause of the pseudo joint, so-called coracoclavicular joint. If the space between these two bones is very narrow, then it could create impingement during the overhead activities, and it create a pain. So that's why the precise injection could be very intelligent tool in our hands. MRI, especially the high resolution MRI, could show this capsular hypertrophy around the AC joint, and if you see, if you watch the data, it's quite reliable. However, there is not a big association between the clinical findings and the MRI. So also be aware to do not over-recognize the inflammatory reaction in the joint. I think the best way, the best tool is to compare both sides. And if you do the MRI of the contralateral AC joint and you see exactly the same type of synovitis or hypertrophy, then you can go further. And it's possible to visualize it also in a simply ultrasound examination, but of course not always we can obtain that good results. And a third pathology which can mimic the AC joint problem is painful os acromiale. This is something very typical for volleyball players. The epidemiology of the os acromiale is not really known, not clearly known, because there are different data about that. But if we have a painful os acromiale, it's something which is very difficult to treat in the athletes. Personally, I have a bad experience with this disease, and 2 of my pupils, they have to finish the career because of the painful os acromiale. These are the data about the injections, so it could be also a good tool for treating this pathology. If we use the single injection with the corticosteroids, we can obtain very good results, even long-term results. Some of the authors reported it can last 12 months. Some of them that at least 21 days. It's the term of the peak of the corticosteroid function. But personally, I'm used to use the corticosteroid injection, especially for the patient and sportsman in the middle of the season, and the pain relief. It's something which is almost always obtained. And the surgical treatment. This is a very simple procedure. Of course, the decision is not that simple like a procedure is. In the majority, the distal clavicle resection it's well described, and the work perfectly for the normal population, for the common population, but not always for the active sportive people. The open kind of historical data, this is the data, but it's at least 1 centimeter too much. The insertion of the superior ligament, it's at least 1.5 centimeter from the edge of the clavicle. So if you cut 1.5 centimeter, you lost the stability of the joint. So it's too much. Arthroscopic treatment, there are 2 options: direct visualization from the top or indirect through the bursa. Through the bursa, it's probably much easier to visualize all surface of the articulation. But some people used to use this small optic for that and make just a slight debridement, the cut of the cartilage, even within the brushing the bone. So it works as well. There is the article from the last year from the Turkish team. They show that they have a very good outcome after that. Of course, we may risk instability after this procedure, but we have to be prepared for this procedure. Then we have to know the anatomical relation, and we're supposed to know that only half of the patient has an oblique positioning of the articular surface. 30% they have a straight line, and 3% has a very difficult situation to be resected because it's inverse for this most common variation. And the arthroscopy, as I said, it's very quickly procedure. I don't think that it's the reason to show the whole procedure, but we have to preserve this structure. This is the posterior ligament. This is what I touched with the old style vapor. This is the posterior capsule and posterior ligament. It goes obliquely, and it keeps the stability of the joint. The complication, of course, it can happen, especially if we perform inadequate resection. It could create a pain, or if you live too much in a cathedral roof, so-called. So if you keep the connection between the edge of the clavicle and the acromion, then it could create a more severe pain than before the operation. Be aware of that. Always control what is inside, what left inside, and then. On the end, if it's not helpful, our procedure was not helpful, we have to once again ask the question to ourselves if the diagnosis was right. The pathology behind the AC joint, they are not that simple like it looks from the surgical perspective only. In the complication, we can have a weakness and a deltoid and trapezius reattachment problem. And also it could create some potential less stability in front of the next surgery. The outcome looks very good. Escola reports 72, Spłaski 100%, Snyder 94. So the results in the literature are mostly similar, and they are mostly very good. What about the arthroscopic? Yeah, this is also well known that we clearly define the intraarticular pathology arthroscopic. We are going there with the microscope 8 times more than in front of the open surgery, so we can really find the pathology if they are existing there. If there is any difference, not really. However, some of these authors present that there is a superiority of the arthroscopic approach. Personally, I'm not doubt that this is the typical arthroscopic procedure. There is no reason to cut the skin and open the capsule to do this. And of course, we have this problem with instability. It's a very large problem. I'm conscious that we do not have time to go through all the aspects of the instability, but just simple anatomical remarks about the stability. We know that the anterior ligament is very, very important because it gives this horizontal stability, vertical stability, and the posterior ligament as well, responsible for the posterior instability. This ligament, what I said before, this is the average range of the insertion, so be aware of two large excision. This anatomical this section shows that the posterior ligament, it's very flexible. It can reach at least 1.2 centimeter backwards together with the edge of the clavicle. So sometimes when we notice and we think that maybe there is a posterior instability, there is correlation between the hyperlaxity and the elastic posterior bend of this ligament. So be aware of over treatment in these cases. And the epidemiology, there is clearly shown that this is the disease which is the most common in the first 3 decades. So our athletes are in this group. The mechanism of injury is well known as well. And for this group, the biggest problem actually it's not only type 3 dislocation but also type 1 without any stretching. It's just a sprain. Type 2 when we have a capsule turn with the preserved CC ligaments, and type 3 really well known. In the decision making, there are some old articles, but I like this article because it's based on very solid and huge data. And there are also some pros and contra. If I ask you who will treat operatively 25 years old volleyball players on the beginning of the season, type 3, who will treat operatively? Offer. 1 and 2. Type 3. The question was type 3. Nobody. Nobody will treat him. So this is a difficult decision because some articles show that the better outcome after the operation we have when we start to operate immediately these people. But we have to be conscious that a volleyball player after this kind of operation can have reduced the external rotation in that way that he have to finish his career. So this is the most difficult question actually, which I found to preparing this topic, and also the same thing in my daily practice. These people, obviously, they have some kind of instability in the posterior aspect of AC joint, but they have this red marked problems after the type 3 dislocation, after the conservative treatment. And they have to be conscious that they will have it. And what about the conservative treatment? There is agreement that type 1 and 2, most of the cases, they are treated conservatively. Of course, we can discuss also about that. But in a type 3, there is an article, also very old, 1997, from the North America, and then the surgeons discuss this during the house meeting, and they decide that this is the consensus. We can be agree or not, but in States there is a very good how to say, the registry of this pathology, and they have this point of view. And for type 3 with this very high level functional demand patients, maybe the early intervention it's a better solution. We don't actually know. The operative procedure, the main principles, it's recreate the anatomy. So the anatomy, it's the crucial word in this operation. Not only the CC ligaments, but also the AC joint ligaments supposed to be repaired. What about the Manport procedure during the reconstruction of the AC joint? Not recommended for the acute cases, but when we perform the ligamentous reconstruction, we have to consider that maybe it's a good option. Thousands of techniques. Don't know what to use, what to choose for the athletes. For the majority, the gold standards in early intervention, it's some kind of bracing of the ligaments, like a Minar technique. And for the chronic instability, the most common is our Weaver-Dunn procedure, which was performed arthroscopically. I personally start from the arthroscopic Weaver-Dunn procedure, then I stop because I find that I cannot recreate the anatomy of AC joint. So I stopped. This is only one procedure where I really refuse to do anymore arthroscopically. I do arthroscopically assisted preparation of the coracoid process, but I stopped Weaver-Dunn, and I do, following the previous work, autograft with the semitendinous, and I perform this kind of operation like Brzoska described. With a reconstruction of the superior ligament. Of course, the complication can occur. Especially, it's very, very typical that we can have a superficial wound problem with the healing. And in the conclusion, I think that type 3 is something which every of us have to deal with. Personally, I'm not operating the sportsmen on the beginning of the season. I try to treat them conservatively, and then I think that the reconstruction of the old structures, it's much more efficient than just early intervention. So being here, I would like to invite you once again to Glasgow, to be with us, to join ESCA, to join ESA as well. There is a lot of space for full, energetic people, and as you are in Greece. So thank you very much. Thank you for your attention.